All right, I'll introduce Janice Gogan in just a minute, but let me go ahead and let everybody else introduce themselves. Why don't we start out with Amanda?
Thanks, Sharon. My name's Amanda McClendon. I am the Utilization Management Behavioral Health Clinical Manager here at Coordinated Care. And so excited to be doing this with the rest of the panelists, and thanks everyone for joining us.
Awesome, thank you. How about Dr. Bigelow?
Hello, I'm Dr. J.R. Bigelow. I work with North Sound ASO. I am a discharge liaison with Western State Hospital.
Okay, Raynell Roberts is also going to be joining us shortly. Colette, do you want to introduce yourself?
Morning. I'm with Healthcare Authority, Colette Rush, one of the clinical consultants. I work closely with the liaisons and these subjects that come up. Thank you for being here very much.
All right, and Alexander?
Hi, I'm Alexander Stoker. I'm the supervisor for the Adult and Involuntary Services team at the Washington State Healthcare Authority.
Awesome. Lindsay, do you want to introduce yourself?
Hi there, Lindsay Green with Coordinated Care. I am just here to help make sure things go smoothly and the recording works. So I'm here for tech support. Feel free to reach out in the chat if anybody needs anything.
Awesome, thank you. And how about you, Jerry?
Yeah, good morning, everyone. Jerry Perez with Community Health Plan of Washington, Regional Manager for North Central Washington area. So similar to Lindsay, I'll also be monitoring the chat, providing support. And so, yeah, thanks everyone for being here today.
All right, fantastic. Did I miss anybody before I go on to introduce Janice? I think I got everybody. So I want to introduce Janice Gogan, who's going to be our primary trainer today. Good morning, Janice. Janice is a graduate of the American Family Therapy Program at Chapman University and also holds an MBA in Healthcare Administration from Western Governors University. Janice has worked in a range of settings, including crisis centers, inpatient substance abuse treatment programs, community behavioral health agencies, and state psychiatric hospitals. As a therapist, Janice enjoyed being part of the recovery journey for individuals experiencing a variety of symptoms, including those of complex trauma and borderline personality disorder. Currently, she is the Director of Community Transitions with the Behavioral Health Administration within the Washington State Department of Social and Health Services. BHA has oversight of the state psychiatric hospitals. Her role includes collaborating with state agencies and administrators to transform the behavioral health system to ensure BHA clients receive access to care and services they need as they transition from state hospitals to the community and advocate for the new resources and programs where needed. Her hope is that behavioral health recovery can be improved through community inclusion and engagement, development of new resources, more effective education, and increased advocacy, and by improving existing resources. So Janice, I am so thankful that you're able to join us today, and I'm going to pass the baton on to you.
Great, thank you so much, Sharon. And I will go ahead and share my screen for you all. There we go. So thank you all for joining us today. We are talking about some legislation that passed in 2021 that created transition teams for two populations that we serve at the state hospital that are to support individuals better as they transition to the community. So we'll be talking about what that legislation created and how it's being implemented, but we'll also talk about the two different populations as they're a little bit different than our typical civil population that you probably see more frequently in the community behavioral health agencies. So again, that legislation passed in 2021, and we've had an implementation work group working out the details of this for the last actually, it's been almost exactly a year now, maybe a little bit longer. It's been complicated as there's a lot of nuance in the bill and how to implement it. And so it's a continuing, ever evolving process. The great thing is that we're trying to figure out what works and what doesn't, and maybe do some agency request legislation if there's some parts of what was put into law that doesn't work within our processes. So at the end of this, I will be asking for some feedback about one of the areas we're still working on that we're struggling a little bit. The idea here is to, instead of just have the LRA or a CR being monitored by one agency, it's to have a team monitoring the LRA or CR. So LRA, I'm sure most of you probably know, stands for less restrictive alternative, and a CR is a conditional release. And we'll talk about the differences in the populations and how those processes look different. And the two populations served by this, which are the not guilty by reason of insanity, which is a forensic population, and then civil commitments with a special finding of violent felony, have these underlying crimes, violent crimes that the legislation wanted to make sure they were being adequately supported given the amount of risk involved with their history and with their discharge, and when they decompensate, that they could have really serious events happen. So it's thought to be a more robust level of care. So again, there's two populations that are impacted. For those of you that have been in the system, you might have heard about HB 1114 or felony flips. These are patients that have gone through our competency restoration, an evaluation. They're found not competent and not restorable. And so competency in this case is just referencing the ability to understand in and participate in the court process. So it's not related to capacity to make decisions. It's really just, can you understand who the judge is, and do you know what the different pleas are? Can you have a realistic conversation to defend the situation that you're charged with? So both populations start out with that competency restoration process. And so those are found competent can plead not guilty by reason of insanity when they go through their court processes. For those folks that they never regain their competency and then they're not restorable, which means they're not likely to regain competency, then they may get ordered to have a civil commitment evaluation. And then they could either get a civil petition that's just a regular civil petition, and they go to our regular civil services at the state hospitals, the 9180 day, or they could be found to have committed have a special finding having committed a felony, a violent felony. This is a little bit confusing in the sense that it's really unequally applied in different counties. So what we find is that Pierce County has about 99% of the clients that are committed with a special finding of violent felony. And they use it almost every chance that there's a violent felony that's classified under this, that they will almost always go for that special finding. For King County, it's about 50% of the time. And then what we see across the rest of the state, Snohomish County is a little higher than average, but what we see is it's just in the most serious offenses that they're looking at this special finding. So it's not the most equitably applied statute, which is kind of interesting, and it's a court process. So it's not something the state hospital has much of a say in as far as that goes. There's fairly small numbers of these patients at the state hospital. There's about 60 at Western State Hospital that have the special finding of violent felony, and then there's only 3 at Eastern State Hospital right now. For the NGRI, I don't know the total numbers of patients, but we do about 35 discharges per year as a conditional release to the community combined at both hospitals. So,
Hey, Janice, we can't see the PowerPoint, so I just wanted to.
oh, I thought I was
Yeah.
sharing this whole time. Okay, sure. Can you see it now?
Yes.
Yes, we got it now.
Okay, thanks. Thanks for letting me know too. Okay, so the transition teams look a little bit different because of the legal requirements of different populations. So for the civil population, the state hospital social workers used to follow the patients in the community for the length of their LRA. This was sort of problematic for us because we don't have any legal authority over someone once a civil patient, once they discharge from the hospital. So we eliminated that practice as this was implemented. And so it has the behavioral health agency being assigned as the care coordinator for the purpose of the monitoring the LRA and all of the LRA requirements that are in statute. It also adds a specially trained community corrections officer. And so this did come up in session as something that we struggled with because it seemed like it was, criminalizing the mentally ill and adding in a criminal oversight to the process. And it passed, so we had to implement. And what we found is our relationship with DOC and working out and making sure that we've implemented this well is they have the same vision we do, and having this not be punitive, allowing for patients that have this history of serious mental health symptoms that sometimes result in committing criminal acts to have a different relationship with law enforcement and CCOs by having them have a more supportive and non-punitive role in this. And so we worked really hard to make sure the special training is person-centered, helps them understand the mental health concerns, and then is really a supportive process and not a punitive process for them. For NGRI, it's a little bit different because with not guilty by reason of insanity, it's a very court-driven process. So where the treatment team may decide if someone can get grounds privileges or go on a leave to the community for civil, for not guilty by reason of insanity, those things all require a court order. And so does a CR to the community. And the difference being state hospital LRA is for like 365 days for civil. For not guilty by reason of insanity, it's the maximum time for whatever the index offense was. So for a lot of our folks, that means the CR could be for life unless they petition for an unconditional release. And that is frequently seen for things like murder and murder too, where those may carry life sentences. The difference here is the state hospital does still have legal authority while an individual's on a conditional release for NGRI. And so the state hospital will be the care coordinator for these patients. And then the behavioral health agency and the CCO are the other members of the treatment team or transition team, sorry. And we recognize that a lot of our not guilty by reason of insanity folks may not qualify for a behavioral health agency. They are often much more stable than our civil folks and have had longer periods of treatment, and the bar for them getting access to the community is much higher under the not guilty by reason of insanity. So they can be, the behavioral health agency and the CCO can be omitted if the court decides to do that. And let's see, I see something in the QA. Just to confirm, this is behavioral health agencies that are authorized to serve patients with an LRA. I'm going to assume the answer to that is yes. Colette, just making sure I'm correct on that. Well, we'll verify that with Colette. I do want to say that while these patients do have a much more concerning criminal history, especially when they decompensate, that we do provide many layers of independent oversight beyond the treatment team and even the court. So for the civil side, there are case consultations or risk review boards, and the forensic side has a risk review board. And this is for both populations, and it's made up of the clinical leadership at the hospital that are putting eyes on the case, giving opinions on the case, and just providing that first layer of independent oversight. And then we do, both of these populations have to go before a public safety review panel. And so they review and give opinions and recommendations on whether patients should have access to different levels of privilege in the community, up into including a CR or an LRA into the community. The behavior, we do then take those public safety review panel recommendations up to our Behavioral Health Administration headquarters review team, which is the clinical folks and our assistant secretary that review and make final determinations for the civil patients. And we review and give recommendations that will eventually go under the court for our forensic NGRI patients. For folks that came in on a index offense that was a sex offense, we also have an end of sentence review committee, and they look at the case. So even if you've never been convicted of a sex offense, they may say that you need to register as a certain level of sex offender. They can also say, hey, this person needs an independent evaluation to see if they qualify as a sexually violent predator under RCW 7109. Folks that get that designation and are committed to our special commitment center out on McNeil Island, and they would not be then going into the community. So I did want to take a moment and discuss the difference between a civil conditional release and an NGRI conditional release, because same terminology, very different document. So with the NGRI, they are court ordered for conditional release, and it has to be, like I mentioned, all sorts of privileges. So anything from staff escorted community outings to unescorted grounds privileges, unescorted community outings, and then including that conditional release to reside in the community. And as I said, they are often for the life or whatever the max sentence is on whatever the index offense is. People do think that it's like in TV where you can like plead not guilty by reason of insanity and go check yourself into a mental health hospital for a few months, and then, you know, all of a sudden you're well and you get out. That is not the reality of these cases. They have a lot of oversight, and there has to be evidence of a significant mental illness or substance use disorder in order to qualify for that kind of a plea. So they have conditions similar to the civil LRAs and CRs. And then anyone that's getting one of these CRs would qualify for a transition team. I'll also add that the state hospital has the right to say that we want to pull the person back in on the NGRI and can get the person detained while we're working on that. And it does not go through the normal DCR process. So under this, that would be a transition team recommendation, and we would work that out. For civil, a CR is not a court order per se. It's a conditional, it's sort of an extension of that, the rest of that ITA order. So it is part of the order. It can be revoked, but it's not a new order. And so what happens is, say if you're on day 175 of your 180-day ITA order, the CR would be for 5 days. So fairly useless. If it's day 3 of your 180-day order, then the CR would be for 177 days. And this is a termination by the treatment team and not the court to go ahead and release them on a conditional release. The conditions look pretty similar to a less restrictive alternative order. I believe the only difference is it doesn't require a safety plan within it. And I think we generally do them anyway. Individuals, civil individuals, even in that special finding population, do not qualify for a transition team if they release on a conditional release from civil. They do if they discharge on a LRA. And again, state hospital LRAs are for 365 days. They are stepped down from care from an inpatient setting. The court approves the individual being released before the end of their court order period, and then we spell out the conditions. And so special finding a violent felony population qualifies for the transition team. The other civil folks do not. So now getting down into what does the transition team actually do? So a referral is going to be made to a behavioral health agency by the Western State Hospital or Eastern State Hospital social worker, or by the managed care organization or behavioral health administrative services organization liaison while the person's preparing for discharge, or while we're in the process of putting together the court order process for NGRI. Ideally, we're getting those intakes completed prior to discharge, and the BHASOs have funding to reimburse the behavioral health agencies for doing those intakes. If the individual is NGRI and they don't qualify, then the behavioral, they're not maybe functionally eligible, or they don't have Medicaid, whatever the reason they don't qualify, then the behavioral health agency, that we can ask the court to admit them from the transition team. The problem we're having right now is that the NGRI process is significantly longer than the civil process, as we have to go through court, and court can be delayed many, many times as defense attorneys or prosecutors ask for continuances. So we can put the plan together, and then we send it to the PSRP, and then we send it to BHA headquarters, and then that takes about a month, and then it could be another 6 months where we've got court on the back end of that. So doing the intake before that is problematic, but not doing the intake before that is also problematic, because otherwise then we're sort of relying on a behavioral health agency to be a part of that transition team when they haven't done an intake, don't know if the person's eligible for services. So that's something I'd like some feedback on at the end of this. Sorry, I'm reading the comments there at the end of the presentation, because we're still trying to sort out how exactly are we going to do this, and what's in the best interest of all the parties to try to get the to streamline the process and not make it cumbersome on any one party. So then an individual from the behavioral health agency has to be named in the court orders to be a member of the transition team. And so that gets communicated back to the social workers at the state hospital so they can inform the other transition team members and be added to the court orders. Once the transition teams identified, then ideally they would have a meeting with the treatment team, get some information, make sure there's a nice warm handoff, and to introduce themselves to the patient and help them be more comfortable with their team moving forward. I can tell you that when I went to Western and I talked to the special finding of violent felony folks about it, a lot of the patients were really excited that they would have this transition team to help support them in their recovery. So I've not seen any cases where they've been against it. Even the corrections officer, most of them have actually signed releases so that the CCO can get information on them before they're appointed to the transition team. So it's been overall a positive for that situation. So then the transition team's responsibility is to make a crisis plan and an individualized plan for treatment. And then those, according to the law, must be submitted soon as possible after intake. We have the templates that are being provided to you that we created for the not guilty by reason of insanity population. The document has to be submitted to court for the NGRI by the care coordinator. So that's going to be the state hospital doing those. Even if the behavioral health agency is a member of the transition team, they're not responsible for that. But with the special finding of violent felony, the behavioral health agency is the care coordinator. And so they would have to submit these documents. We did provide the documents to you. You are welcome to use, edit as you see fit, create a form of your own off of those forms. We just wanted to share our work with you and say, hey, feel free to use this or something similar to this, so you don't have to start from scratch. And then individualized plan for treatment is the terminology used in the statute. And so we continue to use that terminology, and it's really to capture, and if you do this in your own treatment plans, you may just capture it already and use your own treatment plan, but you do want to capture the treatment team or the transition team's role, their contact information, and what types of providers and services the person will be seeing in the frequency. So if they're going to see a med provider and a therapist and a case manager, and maybe the case manager is weekly, the therapist is every other week, the med provider is every 3 months, you're going to want to have that listed out. So if that's not in your treatment plans, that's the kind of detail they're looking for in these documents, and you'll see that in our template. And then the role of the transition team is defined by the transition team. So it may be that the transition team member from the behavioral health agency is the person's case manager or therapist. And then you've got that CCO. Well, maybe we only reach out to the CCO if the person starts struggling, and maybe we don't include them very much. Or maybe this person is highly motivated by praise, and that a regular meeting with both team members or all 3 team members for the NGRI would be really motivating to them. We can certainly build them in there. So it's individualized based on the patient need and how the transition team may best support them. And I apologize for always mixing transition team with treatment team, but we have treatment teams at the state hospitals. And so I use that language all the time. So again, the court orders include the names of all of the representatives of the transition team. The state hospital will be the care coordinator for NGRI, not guilty by reason of insanity. And then for the civil patients with the special finding, the care coordinator is going to be the behavioral health agency. So the care coordinator leads are responsible for scheduling, convening, and facilitating the transition team meetings, making sure all paperwork is completed, including the behavioral health agency intake, individualized plan for treatment, and crisis plan, and submitted to the court. There's also something in the statute that says a monitoring plan may be created or created. And so DOC decided to independently implement a monitoring plan because that is something that they use at DOC. It doesn't have to be submitted to court. So any case where you have a CCO also appointed, they're going to go ahead and complete their own monitoring plan. So I think I touched on this briefly, but transition team meetings and structure, again, up to the treatment or transition team. And you can have meetings with the transition team members, separate members, with the individual, together as a team without the individual. The idea is you're monitoring for compliance, for conditions of release and less restrictive alternative. And the CCO is completing that monitoring plan if they're involved. The requirements that are in the law are that behavioral health intake, the individualized plan for treatment, and then updating that plan as treatment recommendations change. The initial plan is due as soon as possible after the behavioral health intake. And then for the not guilty by reason of insanity, there is a reporting requirement in RCW 1077-160. And it says that anyone that's providing a service to someone on an NG or ICR has to submit a regular report to the court on their status. We are submitting some agency request legislation that smushes that down and says that the care coordinator or any member of the transition team can submit on behalf of the whole transition team. So not every person has to report, but right now every person has to do these reports. And then the individualized crisis plan. And then all these notes down here are just about the templates. Let me see, questions. Yes, we are able to facilitate telehealth intakes. The social worker can help you set that up. And then the forms, I believe Sharon is sending out or can send out. And the PowerPoint will also be sent out. And that is why it is such a wordy PowerPoint, is so that we wanted to make sure that you could go ahead and read it and have it make sense. But we'll also make the recording available to you. So if you have new staff and want to train them, or if you have a certain staff member that's going to be on, you know, the sort of transition team representative when you get a case, or maybe you don't get a case for a year and a half and then all of a sudden you get one and you don't remember any of this conversation, you can go back and review the presentation. So we got some feedback from state hospital patients on how they envision the support from the transition teams. And so if they're really struggling with maintaining their housing, proactive assistance in relocating before they're evicted. I would probably add one step further, like intervention before they're in jeopardy of getting evicted. And that could include getting a release sign from their landlord and helping, you know, come up with some sort of a reasonable accommodation, or getting a medication tune-up, something that might support them in staying stable and in their housing. They would like to be offered encouragement, reminders, and support rather than it being immediately returned to jail or an involuntary inpatient setting, which makes sense. And then the ability of the transitions teams to show sensitivity regarding a person's physical and mental health. And I think the examples that were used were, you know, if someone has a disability that impairs their ability to walk, and maybe it's like a chronic condition that kind of flares up and down, and maybe they couldn't get to an appointment and needed to reschedule, like really being able to accommodate the fact that they may have a physical disability that does impair that, or being able to do a phone check-in instead of meeting in person if they're in a flare-up. So some of it was like that, or if they're really struggling with depression and having a hard time leaving the house, you know, is it possible to have someone come out to the house for an appointment as accommodation, or do we set up Dial-a-Lift or something like that that helps them get to their appointments when they're really struggling and can't take the bus, something along those lines. And this was a bigger one. Like, folks have goals and they really want to achieve those goals, and so they wanted this team to like kind of help them navigate the system. And so maybe someone wanted to go back to college, which can be really overwhelming. There's applications, there's financial aid, takes a lot of organization. They might get overwhelmed by the size of the campus. So could they have some support in, like, maybe you go to the campus with them and you get you get someone at the school to get them a tour, and then you meet with the financial aid and the applications people and kind of handhold them through the beginning of that process until they feel like they can successfully do that on their own. Does it have to be a transition team member? No, maybe you have peer supports at your agency that can provide some of that support. Maybe you have education specialists or employment specialists. And so it doesn't have to be the transition team member, but I think the transition team members can help coordinate. Oh, it sounds like you could use a peer. It sounds like you could use our education support person, and make those referrals and make sure the connections happen. So that was on that. And then assistance with advocacy. And again, that can be something as simple as, you know, working with a landlord to, you know, help keep them stable as they're going through this process. Okay, so there's a special circumstance, and these are patients where they are adjudicated as not guilty by reason of insanity, and then they are not sent to the state hospital, but they are released directly back into the community. So for these cases, it's a little bit complicated because the defense attorney puts together their conditional release packet. And so what usually happens is DOC gets notified first, and sometimes that notification is the person showing up their doorstep. So it's not necessarily the best system because we don't all know that we're getting appointed as transition team members, but we are, right? So DOC will notify the state hospital as soon as they find out. We are trying to work on a training with the defense attorneys so that they understand that they should reach out to all the parties that they're putting into the conditional release plan. And then once everyone gets notified, then the BHA headquarters, so Behavioral Health Administration headquarters and hospital staff will schedule a meeting with some of our executive leadership in the NGRI program and the different state hospital community program leadership, myself, DOC, and then whoever is going to be the behavioral health agency representative. Again, the care coordinator transition team lead is still the state hospital, even though they've never served the patient. And if we are having a hard time finding out which behavioral health agency is assisting the person, then we would reach out to the healthcare authorities involuntary treatment administrator. We have also created a transition team advisory committee because this is new and it involves multi-systems and it's a lot of coordination. So if things are not working well, we want people to have support. So it includes memberships from Behavioral Health Administration, Department of Corrections, and Healthcare Authority. The meetings are held monthly. However, if there's an emergent case or emergent situation, you can request an emergent consult and we will get one scheduled. We are available for case consultation, brainstorming, advocacy for resources. Maybe we know about resources that we might be able to advocate with a manager or leader or system for on your behalf. Problem solving. If the transition team, say for NGRI, disagrees about whether someone should go back into the hospital, we can facilitate a conversation with the transition team and try to get all on the same page. We can support the development of risk mitigation strategies. If anyone in the team has concerns that that the plan isn't adequately making the risk better. And then just ensuring that between all the systems, we are consistently in compliance with the statutes. Any transition team member can request a consult. Consults can be, as I said, requested on an emergent expedited basis. We have created an email, which is TTAC, the Transition Team Advisory Committee at dshs.wa.gov. There in your materials will be a flyer for this, so that you guys have that handy. And we just have some instructions just to include the forms that you've submitted, the individualized plan for treatment, monitoring plan, and crisis plan. The reason for the consultation and any pertinent details we would need to review and identify whether it is routine or expedited. Currently, we are using a tri-agency leadership on this, and so they're considered co-chairs, and we rotate each month, and all of us have access to the mailbox so that we can answer all of your questions. Who to call for questions. So if you have patient-specific questions, you can certainly contact your MCO liaison or BHASO liaison if they're not enrolled in Medicaid. For transition team questions for specific patients, you would contact the care coordinator, or if you are the care coordinator, you may want to just reach out to your other transition team members. And then for system level questions or any of the consultations that we listed, you would reach out to the Transition Team Advisory Committee. And that is the end of the presentation. So first I wanted to see, so the forms, Sharon, are you sending out all those documents?
Yes, I will be emailing out all the documents to those who've registered for the training.
Great, thank you. Colette?
Hi, so was a couple of questions. Sorry, I missed the first one. I couldn't find my mute in time. There's a couple of questions not from BHA is not licensed. They're not licensed to serve this population. One comment, and they're wondering about needing to do this. And another one was not familiar with this terminology. So I'm just wanting to confirm that Sharon, I think you said the behavioral health agencies that were invited were ones that were licensed or certified. I'm not sure what the credential is for able to do CR and LR monitoring, right? And so so if there's other behavioral health agencies that are on the line that are not approved or authorized to do CR and LR monitoring, if I understood those questions right, this would not apply to them. Could you speak to that?
What was that, to me or to Janice?
To you, Sharon,
Okay.
or whoever can answer them. There were just a couple of different questions. I think there were two different BHAs that asked if they're not licensed to provide services for this population. I'm assuming they mean that they're not licensed to do CR and LR monitoring. But anyway, just wanted to, if that person is on the call that could give a little more information about your question, that would be helpful.
Well,
But
I think we can definitely get some more clarity around that. You know, often in Eastern Washington, there may be one agency that's monitoring the LR and one agency that's actually providing the treatment. So I would assume the people who are on the transition team are the people who are actually providing the treatment. So we will get clarity with the behavioral with Janice and Colette and send that out when I send out the materials.
And I'm not seeing any other questions we haven't answered. There is a hand up.
Yep, we do have a hand up, so I'll allow to talk. So let's see. Here we go. Becky.
Hi, it's Becky Olson Hernandez from Compass Health. I have just two quick questions. One might be more complicated. The first is it talks about a referral to the behavioral health agency. Is there a possibility when receiving that referral to deny that referral, either for resource concerns or potentially that was an inmate who we had prior interactions with that put our staff at risk, or some sort of reason that we would want to then deny that referral? Is that a possibility in the workflow?
Colette, we were just talking about this yesterday. So, I mean, I think whatever your usual reasons are for accepting or denying a client would probably apply here. Is that correct, Colette? Or maybe this is an MCO question.
That's true. We realize there's capacity issues at times, or workforce issues, and we do know that there's some denials for that. And then the normal reasons you would. We're hoping that the agencies we do have out there can serve these patients, of course, but just to let us know, the reason why that you would be denying them.
Sure, I have no reason to think we would act in good faith, of course, right? That there are some
Right. There's some situations. Mhm. Yeah.
The other question I had really had to do with issues of confidentiality and privacy. And I'm wondering if the team has worked through any privacy issues given the various populations that you're speaking of. So some under 1077, some not. have we discussed issues of privacy and how those will be handled?
So within the statute, it allows for sharing of behavioral health information within the transition team. So, and it's written into both 1077 and 7105 for this purpose.
All right, thank you for that.
And there is a King County outpatient mental health benefits for low and medium levels of care pays for 1 to 2.5 hours of service per month. I would say if someone hits that range of low and medium, that they would probably only need that level of care service per month. Probably a lot of our civil folks, the special finding folks would be in the high range of level of care. And it looks like Renelle may have some more information that can be helpful. Renelle?
Hi there. Yeah, this is Raynell with King County. Janice, you are absolutely right that if somebody is only coming out with our population health stratification with a low or medium, that someone in these populations is not going to do that just by default of coming out of Western. That's not going to happen. So it'll be an expectation of a higher level of care for that and reimbursed accordingly.
Awesome. Thanks, Renelle.
And looking at the chat, we do have one question concerning King County. I don't know if you want to take the lead on that one, Janice?
That was the one I just talked
Oh,
about.
sorry. Okay.
That's okay. And that is that most of our folks, Jerry, will qualify for a high level of care just by the nature of discharging from a state hospital. All right, I don't see any other hands or questions. And so just briefly, I wanted to bring up, so for the not guilty by reason of insanity folks, like I mentioned, the time we put together the plan and how long it takes to get all of the different reviews and then go to court, and court may be delayed over and over again due to continuances. We're trying to figure out how to time that intake. And so whether it's we reach out to a behavioral health agency, we get that commitment that you guys are going to be a part of the transition team pending the outcome of the intake. That could be opportunity A. Opportunity B is we go ahead and get that intake done. And if they don't qualify for your services, which a lot of them we're sort of suspecting will not, then you can then we can omit you from the court process once that intake's done. And so having worked in a behavioral health agency before, I know that there's probably issues with doing an intake and then maybe not serving someone for 3 to 6 months. But also thinking about, well, if it's not likely that I'm going to end up on that transition team, I'd rather be like, go through the intake and be able to be omitted instead of kind of waiting through the whole process. So we wanted to get some feedback from you guys on which made most sense. If there's any comments to put in you could put in the chat, or you can raise your hand. We'd be happy to hear them. Or it could be those choices sound equally good since we're not seeing any feedback. Well, either way, you can send your feedback to your any of the folks that set up this call, to the Healthcare Authority, to Sharon, Renelle, JR, anyone that you've got a relationship with that's and Amanda that's working on it, and they can go ahead and give me that feedback back later, and we'll make sure to include it because we want to get your feedback so that we can try not to burden you in this process. We understand. I actually, when the bill was up, I was like, why are we trying to put behavioral health agencies with our insurance folks? This doesn't make a lot of sense. Most of the time when they're ready to go to a CR to the community, we get them either a private therapist and med management, but I don't know that a lot of them are gonna have the acuity that would qualify for outpatient, but we'll see. So Ellery court order with no knowledge of behavioral. Okay. We currently provide a monthly summary report to our county crisis department. Is this changing at all? I would say probably not. I don't recall it seeing anything about that in the law, so I'm not sure if any of the MCOs would know.
Yeah, those shouldn't be impacted
Okay.
by this.
And then there are also times we receive a LRA court order with no knowledge of being placed as the behavioral health agency on it. Any recommendations? If that is coming from a state hospital, definitely reach out to your MCO or BHASO liaison, because they should be coordinating that as part of the discharge planning with you. And so you should not be being placed without your knowledge as a member support of the LRA, is my understanding.
It's JR. Yes, as part of the discharge planning for anybody that's coming from Western State Hospital out into the community, part of our job as discharge liaisons is to make sure that the agencies have all the information that they need, that they have the availability, and that they have all the records and the documentation on that person. But that's just discharges straight from the state hospital. I'm not sure if what you mean is if it's coming straight from the court or not.
JR, are you referring to those folks, NGRI folks who never go to the hospital? Is that what you're thinking that question is about?
That's what I'm wondering, if that's what they're asking about, because I can only speak about individuals that are discharging from the state hospital.
Yeah, and the NGRI ones are CR instead of an LRA. But yeah, if you get a CR where you're put on one, that means the defense attorney put you on for the NGRI folks. And we're gonna try to resolve that through training and making sure they have all the contact information they need so that they're reaching out to people and not just putting them on and not notifying us that something's coming our way. The other thing, and I've been thinking about this quite a bit, is there's some behavioral health agencies that want to be more involved prior to discharge and at least have a conversation about any sort of risks or what's been working with patients. And so, there is that, coordination of care allowable within HIPAA and reaching out. And we certainly have no concerns about you reaching out to your liaison and the hospital so that you can have more information on the patient. We want to make sure that I realize as we've been going through this process that I used to monitor LRAs and I would not even much know about the patient or why they're in an LRA or why it was important. And often the index offense, like I mentioned, is a violent felony and they're not getting that special designation. And there may be some really important risk factors that you may want to be aware of, or your team wants to be aware of. So we are just encouraging collaboration and communication amongst the, between the behavioral health agencies, the liaisons, and the state hospital social workers, so that everyone's getting the same kind of information and feels that they have an adequate amount of information to be able to provide services and support in a safe manner. Alrighty, we are right at the end of time. So I do want to thank you for your time and attention. Feel free to reach out to any of the organizers if you have additional questions, and they will get back to me if any of them are for me, or they will be able to answer them if they need to come from the Healthcare Authority or your MCO. Thank you.